Hi, and welcome to day 2 of this week's Crack the Case. I am Onyema Ogbuagu, an associate professor of infectious disease at Yale School of Medicine. This activity is jointly provided by National Jewish Health and Bonham CE. This program has been supported by an independent educational grant from Gilead Sciences, Incorporated. So yesterday, I presented the case of a 70-year-old gentleman who is a smoker who presented initially to the ED with a fever to 100.5 degrees Fahrenheit, several days of dry coughing spells, and tingling in his extremities for 2 days. He had been vaccinated, but had received a booster more than 9 months prior to his presentation. And he'd also received a visit from his niece who had come from Southeast United States. Now, while in the ED, his tests returned positive for SARS-CoV-2. And in that context, he experiences a clinical deterioration with his temperature rising to 100.8 degrees Fahrenheit. He becomes more short of breath, and his oxygen saturation drops from 96% when he initially presented to the ED to 90% on room air. Given the change in his clinical status, this patient is admitted. You see the chest radiograph obtained from this patient shown. So let's start to think about what conditions lead to a radiograph like this. In this image, we see a patient having bilateral interstitial infiltrates. And if you look at the left lower lung zone, what appears to be a developing consolidation. And so in the context of this patient's clinical presentation, one would have to consider that he has a clinical syndrome that's primarily affecting the lungs or respiratory system. And in this case, in the context of an older individual, depending on the time of the year, we have to consider primarily infections or inflammatory conditions that can affect the lungs. Common in this time could be viral infections, thinking about viral infections that are circulating, such as influenza, SARS-CoV-2 infection, and potentially RSV. And remember that even though these viruses show seasonality, they do occur year-round, and so we need to pay attention to these. Remember that other less common viruses, for example, parainfluenza, could also cause disease in this individual. On the differential diagnosis, you may have to consider other atypical pneumonias such as Legionella and Mycoplasma that can also present with the findings shown. And do not forget that individuals who have viral infections can have other comorbid viral conditions or secondary bacterial infections. Now, obviously, we would need to work with this individual to try to identify the offending pathogen. And we have a range of diagnostic tests that we use. Remember that this patient is in the hospital. And so there we have much more access to much more sensitive testing. We do know that there's a proliferation of tests that can be used to identify SARS-CoV-2 infection, including rapid antigen tests that could be done in outpatient setting and self-administered. However, within the context of the hospitals, we do have access to much more advanced molecular techniques that are more sensitive. And you really want to pay attention to the fact that rapid antigen tests can be negative very early on in a presenting syndrome. For instance, this patient had symptoms only 2 days prior to coming in. And in these cases, it's not unusual for a rapid antigen test to be negative. And so in this case, in a hospitalized patient, checking a polymerase chain reaction test, a PCR test, would be a critical testing to perform for these individuals. And remember, we do have multiplex testing such that we can assess for SARS-CoV-2 as well as other circulating viruses such as RSV and influenza. And in this patient, the results eventually returned positive for SARS-CoV-2. Now, we also need to think about other symptoms that mimic COVID. We do know that there is no unique or pathognomonic presentation of COVID that essentially differentiates it from other viral illnesses. However, we did observe early on in the pandemic that people had unusual symptoms such as loss of taste and loss of smell. And certainly those conditions should bring to your mind that this individual could have a SARS-CoV-2 infection. Now, we need to remember in a febrile older patient who is a smoker, that there could be other medical conditions, such as even a COPD exacerbation that could present that way. When we look at his radiologic findings, we do know there's a host of inflammatory, rheumatologic, autoimmune conditions that could also cause bilateral interstitial infiltrates. We know that infiltrates can also occur in conditions such as pulmonary edema. And so we need to keep a broad differential diagnosis in these kind of individuals. However, this individual tested positive for SARS-CoV-2. And do not forget that some of these individuals can also have other organ systems involved. Our patient had abdominal pain. We do know that COVID can affect the GI tract. And he also could have a myocarditis, which can explain pulmonary edema, for example, in his lungs. So we need to think more globally, not just about the respiratory symptoms related to COVID-19, but all the other organ systems that could be involved here. Now, obviously, one thing that has emerged as a determinant of how we treat this patient is staging his disease. And we stage COVID-19 disease based on patient symptom presentation, the X-ray findings, and the requirements for oxygen or ventilatory support. When this subject initially presented, they did have relatively milder clinical symptoms with shortness of breath. Their oxygen saturation was 96%. And also they did have lung infiltrates, but that seemed to involve less than 50% of their lungs. And so this patient would have been categorized as a patient with moderate COVID-19. However, when he experienced clinical deterioration as evidenced by worsening shortness of breath, he now had a decrease in his oxygen saturation to 90% and required supplemental oxygen. His respiratory rate was 28 cycles per minute. His blood pressure was 140/90, and his temperature was 100.8 degrees Fahrenheit. He now reports that he's lost his sense of smell and complains of rhinorrhea, and appears to have experienced progression of his lung disease on radiologic tests. He clearly had progressed from moderate to severe disease. Now, the patient was admitted to the hospital due to the rapid progression of the infection and his underlying comorbidities, which put him at increased risk. Radiologic exam shows bilateral patchy ground glass infiltrates and consolidative changes in the mid to lower lung. And the pattern of the opacity suggested lower respiratory tract involvement of COVID. His lab tests showed a leukopenia, atypical lymphocytes, elevated LDH, CRP, and D-dimer. Low-flow supportive conventional oxygen therapy was instituted, and he received intravenous fluids. Now, this patient's symptoms were managed with acetaminophen as an antipyretic, dexamethasone, heparin, and remdesivir, because he was considered high risk, now having been placed on oxygen supplementation. His other medications, such as an ACE inhibitor and a statin, were continued for his chronic condition. Now, let's consider why this individual was placed on dexamethasone. We did see data from the recovery trial that in patients who were hospitalized with COVID-19, that there was a shorter duration of hospitalization and lower 28-day mortality among the subset of individuals who received oxygen and required ventilatory support. This benefit was not seen in individuals who are not on oxygen. Thus, dexamethasone is recommended in the NIH guidelines for patients who are admitted to the hospital who require supplemental oxygen. Now, interestingly, in this patient's medical history, he was actually vaccinated and had received a booster. However, we do know, because of the emerging variants that have shown both increased transmissibility and also the ability to be more immune evasive, we see that breakthrough infections have actually occurred in individuals who have been vaccinated or even had antecedent prior infection because of how the virus has changed. Now, we need to always remember that the studies continue to show significant benefit for vaccinated individuals compared to non-vaccinated individuals, and also for boosted individuals above those who have not been boosted. And we've seen the outcomes even more significant when it comes to rates of hospitalization, severe disease, and death. And for example, the CDC does report that there are much higher rates of deaths among unvaccinated people compared to vaccinated people by 15-fold for individuals 12 years and older, even in the Omicron era. We need to also remember that the treatment for individuals with breakthrough infections is no different. And recent studies have shown that antiviral therapies are effective in individuals who've been vaccinated and conferring a benefit compared to those who are unvaccinated. So let's think about why this patient was placed on heparin. Now, early in the pandemic, there were multiple reports that showed a higher rate of venous thromboembolism in individuals with COVID-19, particularly in those who were hospitalized. And we know that this occurs because of procoagulant responses that accrue from the interaction of the coagulation dysfunction, as well as host defense mechanisms and immune responses that occur in response to SARS-CoV-2 infection. And thus, studies evaluated the role of anticoagulation to prevent venous thromboembolism. And thus, the NIH guidelines currently recommend that individuals receive a prophylactic dose of heparin if they're at risk for venous thromboembolism. And for a group of patients who have elevated D-dimers, such as in our patients who require oxygen and have no risk for bleeding, that a therapeutic dose of heparin may actually be administered to these individuals to protect against venous thromboembolism. Of note, we've also seen that individuals who've recovered from COVID in the post-recovery era can also have a higher rate of venous thromboembolism, and so clinicians need to be cognizant of this. Why was this patient also placed on remdesivir? We saw from the first randomized placebo-controlled trial, the ACT-1 study, that evaluated remdesivir compared to placebo in individuals with a wide spectrum of COVID-19 disease presentations, but who presented within 10 days of symptom onset, that there were a faster time to clinical recovery in those who've received remdesivir. And since then, we've seen real-world studies and aggregated data that continue to show that benefit for faster times to clinical recovery in individuals who received remdesivir. However, the survival benefit is less clear. And we've known that emerging data also suggests, especially for an antiviral agent, that earlier treatment is better than later. And this was showcased in the Pine Tree clinical trial data, where individuals received remdesivir within 7 days of symptom onset, and it was shown to reduce the composite outcome of hospitalizations and death among a high-risk unvaccinated population. So this patient responded to therapy and initially reported nausea and other GI symptoms following remdesivir administration, but was able to tolerate it for 3 days as an outpatient. No underlying bacterial co-infections were discovered. Within 36 hours, his fever resolved. And though he was still coughing, he had improved and was able to catch his breath. His oxygen saturation increased to 96% by day 3, and his respiratory rate fell to 20. His requirement for oxygen continued to decrease over 3 days. Blood pressure was within normal limits, and he was discharged home after 3 days in the hospital with instructions to monitor his symptoms for post-COVID syndrome, which can include symptoms like fatigue, brain fog, prolonged shortness of breath, and loss of taste and smell. And he was counseled to quit smoking and exercise as tolerated. Now, this patient has fully recovered and is doing well. It's likely in this patient that prior vaccination reduced the severity of his symptoms. Reassuringly, repeat imaging at 1 month showed resolution of the ground glass interstitial infiltrates and consolidative opacity in the mid to lower lung. Thank you so much for joining us today. Please make sure to claim your CME credits visiting bonumce.com/bit.ly/crackthecase1. Complete your post-survey and evaluation. Be sure to click like and follow for more social media CME.